I'm going to discuss adult chlamydial conjunctivitis today. I'll be covering pathogenesis, diagnosis, and treatment. Starting with pathogenesis. Chlamydia trachomatis is a species of chlamydia, a phylum of bacteria that cannot replicate extracellularly and hence depends on host cells. They exist in two principal forms: a robust infective extracellular elementary body and a fragile intracellular replicating reticular body. Adult chlamydial inclusion conjunctivitis is an oculogenital infection usually caused by serological variants D to K of Chlamydia trachomatis and affects 5 to 20% of sexually active young adults in Western countries. Transmission is by autoinoculation from genital secretions, although eye-to-eye spread probably accounts for about 10%. The incubation period is approximately a week. We need to understand the classification of Chlamydia trachomatis and differentiation between trachoma and adult chlamydial conjunctivitis. As we can see that Chlamydia trachomatis is divided into two categories here. The first one is trachoma inclusion conjunctivitis agents, which are further divided into two serological variants. A, B, and C cause trachoma, while D, E, F, G, H, I, J, K cause genital and other systemic and ocular diseases, and this is the variant we are discussing here in this lecture. While the variant L with further subtypes like L1, 2, and 3, it causes lymphogranuloma venerum, and that is out of our scope and we are not going to discuss that. So in discussing this, we have to discuss the urogenital infection, which presents differently in males and females. In males, chlamydial infection is the most common cause of non-gonococcal urethritis, also termed non-specific urethritis. It should be noted that the term non-specific urethritis is sometimes used to mean urethritis in which both gonococcal and chlamydial infection have been ruled out. Chlamydial urethritis is frequently asymptomatic in men. Chlamydia trachomatis may also cause epididymitis and can act as a trigger for Reiter syndrome. In females, chlamydial urethritis typically causes dysuria and discharge. It may progress to pelvic inflammatory disease, carrying a risk of infertility. Approximately 5 to 10% of women with pelvic inflammatory disease develop perihepatitis, which is Fitzhugh-Curtis syndrome. We need to remember our syndromes. Now, patients present with symptoms of subacute onset of unilateral or bilateral redness, watering, and discharge. Untreated, the conjunctivitis becomes chronic and, though self-limiting, may persist for several months. It is important to inquire about sexual exposure if chlamydial conjunctivitis is suspected. Upon clinical examination, there is watery or mucopurulent discharge, tender pre-auricular lymphadenopathy. Large follicles are often most prominent in the inferior fornix, as they are seen here in the inferior fornix, and they may also involve the upper tarsal conjunctiva, as we can see here. So we must see both the cornices, the upper and the lower ones. Superficial punctate keratitis is common. There can be perilimbal subepithelial corneal infiltrates. We can see here perilimbal infiltrates, and they may appear after 2 to 3 weeks. Chronic cases have less prominent follicles and commonly develop papillae. So mild conjunctival scarring and superior corneal pannus are not uncommon. As we can see here, there is pannus, and this usually happens in chronic cases. So tarsal conjunctival scrapings are obtained using a spatula or the blunt side of a scalpel blade for investigations. Nucleic acid amplification tests such as PCR are likely to be the investigation of choice in time, but validation for ocular specimen is limited at present. Giemsa staining for basophilic intracytoplasmic bodies is performed by applying scrapings onto a glass slide. Direct immunofluorescence detects free elementary bodies with approximately 90% sensitivity and specificity. Enzyme immunoassay for direct antigen detection is also useful. McCoy cell culture is highly specific. Also, we need to remember cell cultures. I will make a presentation about stains and cultures in the end. But meanwhile, we need to remember them. Swabs taken from bacterial culture and serology may be helpful in selected cases. So coming towards treatment. Empirical treatment may be given if the clinical picture is convincing, pending investigation results. The first thing to do is referral to genitourinary specialist. It's mandatory in confirmed cases, particularly for the exclusion of other sexually transmitted infections, contact tracing, and pregnancy testing. Systemic therapy involves one of the following. The first treatment is azithromycin 1 gram repeated after 1 week. Is generally the treatment of choice, although a second or third course is required in up to 30% of cases. Some guidelines advocate only a single 1 gram dose. Doxycycline 100 mg twice daily for 10 days. Tetracyclines are relatively contraindicated in pregnancy or breastfeeding and in children under 12 years of age. Third option is erythromycin, amoxicillin, and ciprofloxacin. Topical antibiotics such as erythromycin or tetracycline are sometimes used to achieve rapid relief of ocular symptoms but are insufficient alone. Then comes reduction of transmission risk. It involves abstinence from sexual contact until completion of treatment 1 week after azithromycin, together with other precaution as of for many infectious conjunctivitis. Retesting for persistent infection should take place 6 to 12 weeks after treatment. It is important to be aware that symptoms commonly take weeks to settle, and that follicles and corneal infiltrates can take months to resolve due to a prolonged hypersensitivity response to chlamydial antigen. In a patient with adult chlamydial conjunctivitis, other sexually transmitted infections should also be excluded. So that's where we'll wrap it up. And if you like the lecture, please click on the like button and subscribe to the channel. Thank you all.